Hello, this is Dr. Russ. Welcome to another plantar fasciitis video. We did one with Laura a couple of weeks ago. You'll see the treatment here is very similar because most plantar fasciitis starts in the calf. And in order to really treat it, you can't just work the sole of the foot where the pain is. You got to start at the knee. You got to work all the way around the heel and the ankle, plantar and dorsal, and get lots of things moving and release trigger points from the calf and decongest the sole of the foot and sometimes adjust the foot bones. I want to thank you for watching this video. I also want to say thanks to anyone who has become a channel member. That is great. And subscribed. And anyone who's purchased supplements through our full script dispensary. I do really appreciate that. I know you have basically limitless numbers of places you can go for your supplements. So buying them through us, we get a little cut and it really does help. And I appreciate it. I really am enjoying making these videos. I like engaging with the viewer. I would like to know what you would like to see. Would love for the channel to grow, but I'm not going to do the things that a lot of other big chiropractic channels are doing with the scantily clad models and the dramatic pops and yanks and ring dingers that are kind of shocking and bring people back to view, but are not good for the patient. And I don't really think they portray realistic chiropractic work, and I don't think that they portray good quality, professional, effective, and safe chiropractic work. Those are the things that I want to show to the world. So thanks for watching. Please feel free to comment on this video and let me know what you might like to see. This series on plantar fasciitis came out of a comment that someone made several months ago. Sorry that it took so long to get this going, but you kind of got to wait for the plantar fasciitis to hobble in. So here we are. Here's the video. Thanks for watching. Dr. Russ out. Pain is pretty classic plantar fasciitis pattern. Does it start above the heel, Meredith? Or does it start? Really. Nope. So it's really just in the sole of the foot and comes about this far down. Okay. And she's saying it's worse with dorsiflexion. So any stretching of the toe flexors, the Achilles, or the plantar fascia is going to provoke the pain. And it occasionally swells up. And it gets worse throughout the day the more you're walking on it. Is that right?
Yeah.
Okay. And is there an old sprain to this ankle? Is there an old injury?
Nothing comes to mind.
Okay. So just no trauma in the history.
I'd say it was getting worse, and I've changed some things and worked on it. It's getting a little bit better.
Okay. As I recall, it got worse when you had been driving more.
Yes.
Yeah. And so the right foot coming into a lot of plantar and dorsiflexion and a lot of tension being held in the lower leg to hold the foot on the gas pedal. That'll do it. That'll do it. Okay. So it's like a driver's foot. So if we just start with a basic inspection, everything looks beautiful. There's no obvious problem. So that's an initial green light to do some body work. There's no bruising. It's not swollen now. If it does swell at times, I don't see any edema now. If you come look at the sole of the foot, a couple of things we might look for. If it was swollen is one, we wouldn't have this texture in the plantar skin. It would be stretched thin, like, I don't even know. It would be stretched thin and neutral. We wouldn't get this nice terrain on here. The other is we really can see her calcaneus, we can see her malleolus, the metatarsal heads are really visible, so there's not a lot of visible swelling here. When there is swelling around the foot and ankle, a lot of times it will accumulate here, and this is called the sinus tarsi, and it's not swollen at all. In fact, there's a nice divot right there. And Meredith, if you pull your toes up, yep, you see her extensor digitorum brevis pop up right there. If there was a lot of edema there, that muscle would be obscured by that swelling. So we're not looking at a very swollen foot. No frank injury, I think, has taken place. And anytime I'm working with anything foot and ankle, I'm going to start at the knee. And look at everything from the knee to the toes. So let us start at the knee. What I'm going to do is just first check the basic range of motion, and that is full. So the thing that limits flexion in the human body is the calf and the hamstring muscles approximating each other. If those muscles weren't there, this joint would probably go all the way to 180 degrees. And we know it goes into full extension because I watched her walk in, and she was standing with her knees straight. There does also need to be a little rotation in the knee, which we can see here is about 10 or 15 degrees, and that's a normal amount of rotation in the knee. The knee is mostly known for flexion and extension, but it does have to rotate. We're always interested in the fibular head right here, and as I'm rotating her knee internally and externally, I want to make sure that that fibular head moves pretty well. And another big movement of that fibular head is a glide superiorly as you dorsiflex the foot. So this is something that is not as visible, but definitely palpable. As I dorsiflex her foot, I can feel that fibula sliding up. So that's moving well. I'm not worried about her knee. Let's move down into the calf muscle. So the lateral gastrocnemius here, it's a little bunchy. Is that tender?
No.
No, good. So a little bunchy there, a little bit sticky of that superficial fascia there. And the medial gastroc feels pretty normal. So in order to get on the soleus, which is deep to that, I've got to come medial and lateral. If you could get a view from the ceiling on that. So I'm really taking both hands, and you can see both of my fingertips are anterior to the gastroc. So I can feel the soleus from the medial and the lateral at the same time. Kind of pinch it between my fingers. And right here on the lateral side, I'm starting to pick up on some pretty firm resistance. And yeah, that resistance is sustained as I come down. So I think there's some adhesion here on the lateral side between the soleus and the tissues that lie deep to it. On the medial side, it feels like it's moving pretty well. Coming further down, her gastrocnemius and soleus end here, and then this is Achilles tendon. So the myotendinous junction on Meredith is right here. That's all tendon, and that gives us the opportunity to feel the deeper tissues. So the tendon is in the middle. I can come in from the lateral and from the medial to get a sense of the deeper tissues. It's not particularly tense or tender there. That's just a quick survey of the calf muscles. Now we come into the ankle itself. So her knee is neutral and her ankle is neutral right here. When people lay down at rest, usually their calcaneus will come into a little inversion like that. Very few people will rest with their ankle in full neutral. But when you're standing and walking, your ankle needs to be neutral. So I'm interested to know, how does this ankle like being in neutral? So here is calcaneus neutral. It's pretty happy there. It's even got about 15 degrees of eversion. So that range of motion of that heel is really quite good. Let's look at it in the dorsiplantar flexion, and here's where we start to run into issues. So it tracks that she gets pain with dorsiflexion because her ankle doesn't even really like to be neutral. Now, the way that the neurology is in the lower limb, there's always going to be more tone at rest in the calf than in the shin, and so that is why when people lay down, their feet are in slight plantar flexion. So this would be neutral. This is where people lay down. So you have to use your hands to get them into neutral, and she's definitely resisting that position. So what I want to feel for is, where is that resistance coming from? It's a little bit coming from here, and it's a little bit coming from here. That lateral soleus and deep in the ankle mortise joint, the tibio-talar joint. So those are the two things that are on my radar so far. And let's look at the midfoot. Each metatarsal needs to have a nice amount of play at the base and at the head. Yes, the head is the distal part because it's the knobby shape, and this is the base. And Nothing is feeling particularly stuck in the midfoot and the forefoot, the toes. So far, so good. So this looks to me like an issue of plantar dorsiflexion restriction, partly in the articulation of the ankle and partly in the soleus. My tendency is to do the muscle work first in general, but in this case, we're going to start here for a couple of reasons. One is that Meredith and I have been working together for a long time, and I know that I've been here before. And number two, it just feels, in this case, like the restriction is so much more pronounced in this section than it is in here. So again, even though the symptom is here, I think the problem is more on the dorsum of the foot. So actually, Meredith, I want you to turn over, okay?
Sure.
Cool, take your time. All right, so we've got her turned over, which gives me nice access to the dorsum of the foot. And again, just a quick inspection. It's not swollen. You can see the outline of the malleolus here and here. You can even see the dome of the midfoot right there. So I think we have a green light to do some work. And all I'm going to do to start is just a really simple mobilization. So I'm cupping her calcaneus with my left hand. I'm getting the fingertips of my right hand right on the ankle mortise joint, right on that joint line where I want it to fold. I'm using a pull on her calcaneus and a push on the sole of the foot to induce dorsiflexion. And I am sort of training that ankle to fold here. And one of the things that happens with folks in the foot is when they get restriction here, yet they're walking, the foot winds up breaking and folding here, not breaking like fracturing, breaking like folding. And they start to get a breakdown of the midfoot and then a fallen arch. So people can often function pretty well without good dorsiflexion in the ankle, but it comes at the expense of integrity of the arch and eventually pain in the heel or in the midfoot. So there's traction toward me as I'm dorsiflexing and inducing this movement right here. So I'm picturing the dome of the talus rolling underneath the socket of the tibia. And that's kind of helping me visualize what I'm trying to do. And I'm using some muscle here. I'm definitely using some effort, especially sort of a scooping motion now. I graduated from fingertip to the edge of my hand, and I'm really using the strength of my arm to induce this movement. And I just felt actually in that last little one, a nice little extra movement. And again, and one more time. Good. So that was about 30 seconds, a minute of pretty focused mobilization of the mortise. And we're going to move through the midfoot and forefoot. What I don't want to do again is to kind of reinforce that erroneous dorsiflexion in the midfoot, but I do want to make sure that the fascia between the bones and the skin is nice and mobile so that nothing is getting hung up in there that we're going to miss. And so here again is traction toward me, and I'm just gliding along the skin and moving the skin and fascia against the midfoot. Now we're going to go in the opposite direction. As I dorsiflex, I'm pushing that fascia and skin up toward the mortise, and I'm going to cross the ankle and make sure that mobility comes right up here into the distal calf. Again, making sure there's a rotation here as well. So even though the bones here don't twist, more than a millimeter or so, they are flexible. What we really want to make sure we have is good mobility of the fascia, so that everything here can be moving, blood can be moving, energy can be moving, neurological feedback from the foot and ankle are going to be congruent. So if this is really stuck and this is really mobile, it's going to confuse the brain about what the foot is doing. So we want everything to be nice and pliable and mobile. Okay, let's do another round here of mortise mobilization. In fact, this time I'm going to give it a little bit of a yank. Okay, Meredith?
Yeah.
I'm feeling like, so the reason I want the towel there is for my grip. So my two fingers kind of cross right over the mortise joint, and I give it a yank, just like that. One more time. Good. So it's really very much a mechanical process of just loosening it up and inducing and imparting movement into the mortise joint in this case. Okay, and earlier we had felt some restriction here in the lateral calf. And so with her lying supine, we can address that. She can see my fingers here behind and just kind of like creating a fence for her lateral calf to sit on, and then that gives me something to do counter pressure against as I work up the lateral part of the soleus and mobilize it in relation to the gastrocnemius and in relation to the deeper toe flexors that exist deep in the calf. So I would say this is something we would probably have to do a few times in order to really get enough momentum to change this plantar fascial condition. But each session would probably only be about 10 or 15 minutes worth of work. So should be able to do that weekly or twice a week ideally for a month or so. That would be my prognosis. Okay. So now that we've addressed and identified the underlying biomechanical issue, I want Meredith to turn back over and we're going to work the painful area itself and flush that out. So turn on over, Meredith. So this is simple. This is not corrective work. This is more symptomatic relief. And so we're just going to create some movement and gentle sensation through the painful area. Starting at the skin level, very simple. Most of the pressure is coming through my thumb, like this. It's not pokey. I'm not working deep and I'm not doing a pokey thumb. It's kind of the broad part of my thumb. And then the rest of my hand on the outer side of the foot is also stroking distal to proximal for no other reason than it probably feels better than just being super pokey on the sole of the foot. And some people are really ticklish here, and when they are ticklish, the best way to deal with that is to provide some other sensation than just the sole of the foot, and also make sure that your touch is pretty firm and steady. With my left hand, I'm just holding the ball of the foot just to kind of keep it steady. I'm not really doing any traction. I'm not using much pressure, just enough to hold it still. Okay, now we're going to focus particularly on the posterior part of the calcaneus right here. Obviously, the skin is really thick here. The fascia is really thick here. Everything's really dense. It needs to be, but it does also need to be mobile. So we're going to grab it and move it and make sure that it's sliding, make sure that it's gliding. There's not really a risk of gliding it too much. It's really quite well anchored in. So we're just going to pretty vigorously, but not aggressively, get in here and move the fascia around the heel bone, just like so. So people sometimes, you bring a plantar fasciitis to primary care provider. Probably the three things they're going to offer you are physical therapy, orthotics, or cortisone injection, probably in that order. Physical therapy can be great, but you can see how, given what we had to do, kind of your standard PT exercises to stretch the calf and strengthen the toes, while they would be helpful and healthy and good for a person, are not really going to address the issues that we're addressing. As far as insoles go, I very rarely prescribe them. I can make them for folks. I don't love to. Maybe that's a topic we could get into more deeply in a separate video. But the basic issue is, if there's a mechanical issue in the foot that's reversible, I don't want to put an insole in there that's just going to reinforce it and kind of enable the foot. If it's possible for us to reverse it, I think we should reverse it. And then the third thing is that cortisone injection, which a lot of times gives people symptomatic relief, but in and of itself doesn't solve the problem. To me, the ideal of the cortisone injection is when a person's in so much pain they can't rehabilitate, they can't really do anything. You get the cortisone in there to take the swelling down, get them able to rehabilitate, get them able to do some repair and regeneration, and that's the utility of the cortisone injection. But in and of itself, it's not going to solve the problem. If you just do an injection, you're probably going to need another one in 3 to 6 months, and so on. And those injections are not without consequence. They do damage tissue, and so we want to minimize the use.